Today we'll be talking about fever and neutropenia in children, which is also known as febrile neutropenia. Let me give you a case, and from that case, we would try to explain what is febrile neutropenia. Especially, we would be talking about its diagnosis and its management. So, let's begin. So, beginning with this case, this is a 4-year-old girl. She suffers from a malignant tumor of the bone, which is known as osteosarcoma. She has been on chemotherapy, which she has just finished. And after finishing her chemotherapy, she develops a mild grade temperature. Now, this mild grade fever causes concern for her parents. So she is brought to the hospital. Blood workup up done is done. Blood cultures have been taken, and then she is given an oral course of amoxicillin, which she takes for a few days. But the fever doesn't settle. So she is brought again to the hospital, and this time she is admitted and she is started on IV piperacillin tazobactam combination. So she is now taking this antibiotic intravenously. But even after 4 days of this antibiotic change, she is still febrile and the temperature is hovering around at 39 degrees Celsius. Now, so far, the workup that has done, including the chest X-ray and urine culture, is clear. Blood culture has also turned up negative. So the question is, how would you manage and treat this case? Now, take a few moments and think about your management and treatment of this case. We will come to this case later on, but for now, let's talk about the definition, about the etiological considerations, management, and complications of febrile neutropenia. Now, the very first question is about the definition of febrile neutropenia. Now, febrile neutropenia, look at the word. Febrile means fever, neutropenia means low white blood cells, and especially the low neutrophils. Now, febrile or fever simply means a documented temperature of greater than 38 degrees Celsius. So, if it is more than for 1 hour, if the parent says that the temperature has remained for more than 1 hour above 38 degrees Celsius, or if they are using a Fahrenheit thermometer, if it is 100.5 on the Fahrenheit scale or 38 degrees Celsius on the centigrade scale, then we call it fever. Or even if it is for less than 1 hour duration, then any temperature greater than 101 degree Fahrenheit, which equates 38.3 degrees Celsius, that would be taken as fever in case of febrile neutropenia. But remember, when this temperature is being taken, one should avoid taking rectal temperatures in these cases, because infection can be introduced in the gastrointestinal cavity by taking rectal temperatures. So that's why rectal temperatures are contraindicated in this type of situation. So one is fever. Now, fever can occur in many situations, but in this particular case, we associate it with neutropenia. Now, neutropenia basically means that the absolute neutrophil count should be less than 500, or in other words, 0.5 into 10 raised to the power 9. Or if you are taking it in the absolute, then it should be less than 500 per millimeter cube. Now, how do we calculate the absolute neutrophil count? Now, most of the laboratory reports, they give you the absolute neutrophil count as a part of full blood count. But let's say if they haven't done, it's very simple. The total white blood cell count is taken, and then it is multiplied by the percentage of neutrophils that you get as a part of the DLC, that is the differential leukocyte count. You also add the percentage of the band cells in that, and that gives you the absolute neutrophil count. So, absolute neutrophil count, if it is less than 500, then we call it neutropenia. Now, some textbooks, they also take neutropenia as less than 1000. But 1000, even if it is neutropenia, that would be mild. Where it becomes a case of concern is when then it is less than 500, so then it becomes neutropenia. And if it is less than 100, then we call it severe neutropenia. That can cause more complication. So a child who has got fever, which means, again, if it is less than 1 hour, fever duration less than 1 hour, it should be greater than 38.3, or if it is more than 1 hour, then it should be greater than 38 degrees Celsius, and that is associated with low absolute neutrophil count on a full blood count. So if these two conditions are met, we call it as febrile neutropenia. Now, coming to the etiology of febrile neutropenia. Now, if there is fever and there is low absolute neutrophil count, the question is, they are very much prone to develop different types of infections. So we need to understand why the fever is coming and why there is low neutrophil count. Now, the fever can come because of various reasons. Fever can come because of infections, fever can come because of inflammation. Now, some of the common infections that cause fever could be bacterial infections, like it could be bacteremia, it could be inline infections if the child is suffering from some form of invasive um, conditions, or maybe cancer. It can be caused by pneumonia, it can be caused by UTI. Again, these bacterial infections could be gram positive, like Staphylococcus aureus, or it could be gram negative, like E. coli. Then viruses are more common than bacterial pathogens, and respiratory viruses. There are more than 200 different types of respiratory viruses, and then herpes and varicella. They can cause high temperature. Similarly, some of the fungal infections that are not that much common but can be common in immunocompromised children. Those fungi can be like Candida, Aspergillus, Cryptococcus. They can cause fever. Similarly, some of the non-infectious reasons can also cause fever, like drug fever. It can be cancer-related if the child is suffering from some form of cancer. It can be caused by DVT. It can be caused by pulmonary embolism. It can be caused by autoimmune conditions. And sometimes we might not find any etiology for fever even after extensive workup. Now, as far as the neutropenia or absolute low neutrophil count is considered, again, that can be categorized based on the risks. Now, the highest risk of low neutrophil counts comes from those kids who are having chemotherapy. Now, chemotherapeutic agents uh, are immunosuppressive, and they cause decrease in your immunity by causing suppression, by suppressing the production of the white blood cells. And neutrophils are a type of a white blood cell. So they can reduce the absolute neutrophil count. Similarly, some of the kids are not at the highest risk, but they're still high risk. Now, these are those kids who can be having any reason, like they can be suffering from invasive infections, they can be suffering from underlying hematological conditions like plastic anemia, or they can be suffering from different type of syndromes, but they are ill looking, they are not well looking. So any child who's ill looking and has got neutropenia, he has got a high risk. Then there are kids who can have like somewhere between low to moderate risk. So they can be those kids who have got cyclical neutropenia, where the neutrophil count goes down after some time on a regular basis. Or these could be those kids who have got what we call as chronic benign neutropenia. So like it's a chronic condition, it hasn't got any much consequences, but like it's a chronic condition and goes on over a period of time. And then we've got low risk kids, kids who have got transient neutropenia. And these are those kids who are otherwise very well. They're not immunocompromised. They're not suffering from any hematological conditions. And usually, in most of the cases, their neutropenia is caused by viral infection. And the common viral infections, I mean, the URI, the same bugs that cause URI, upper respiratory tract infection, they can cause transient neutropenia. So they are on the lowest risk as far as the risk spectrum is concerned. So we need to understand what is the etiology of the fever and what is the etiology of neutropenia. Only then you would be able to address the cause and treat the child. Now, another important thing is to consider infections. By and large, the most common cause of fever and neutropenia are different types of infections on a background of conditions which causes immunosuppression, especially cancerous condition and those kids who are having chemotherapy. Now, the most common pathogens which can cause febrile neutropenia, remember, the circumstantial evidence can guide us what could be the common causes. Like, for example, gram negative septicemia is considered to be the most concerning, and gram negative septicemia, like being caused by Klebsiella and E. coli and Pseudomonas, they can occur in different types of conditions in which the immune system is suppressed. Similarly, the gram-positive organisms can also, and you should be considering gram-positive organism in those kids who have got indwelling catheters, especially central catheters, or even if it is like peripheral catheters which are there for a prolonged period of time. Then the most common cause could be staphylococci, like Staphylococcus epidermidis, which can like go inside through the indwelling lines, can cause febrile neutropenia. Similarly, if you are thinking about anaerobic infection, that can occur in like deep GIT problems, but they are relatively rare. Similarly, a child who has got HIV, then in that case, you should also be considering tuberculosis. But by and large, the most common causes are viral causes like upper respiratory tract infections, especially if the child is coughing, if he has got a runny nose and he's got upper respiratory signs. Similarly, some of the conditions can be reactivated in a suppressed immune system like herpes simplex, herpes zoster, Epstein-Barr virus, cytomegalovirus, which are otherwise rare, but they can be common in those kids who have got a compromised immune system. Similarly, fungal infections. You normally don't hear about fungal infection that common in your routine pediatric practice. But fungal infections can be very common in those kids who are suffering from a compromised immune system because of chemotherapy, because of prolonged steroid use, or because of any underlying condition that causes suppression of the immune system. So some of the fungi, Candida and Aspergillus, they can cause oral thrush, they can cause skin infections, they can cause lung infection in these kids. And some of the other considerations like autoimmune conditions, they can also cause febrile neutropenia. Similarly, different types of malignancies, like if most common are hematological malignancies like leukemia, lymphoma. Similarly, solid tumors like osteosarcoma, Ewing sarcoma, other types of tumor, Wilms tumor, they can cause febrile neutropenia. Now coming to the workup. Now, what workup, diagnostic workup needs to be done? Now, remember all patients who present with febrile neutropenia, so they've got fever as per definition and they have got a low absolute neutrophil count. Remember, within 15 minutes of triage, you should be taking their bloods, you should be taking their vital signs. And remember, it's very important that you take blood cultures, because once if you start antibiotics, then probably after that taking blood cultures would be of no use. So before you commence them on antibiotics, and antibiotics have to be started within 60 minutes. This time frame is very important, because otherwise they can lead to sepsis, and that can have fatal consequences for the child, because already the immune system is compromised. So remember, within 60 minutes, within 1 hour of presentation, antibiotics have to be commenced. So that's why it is important that whatever you do has to be done within 1 hour. So in 1 hour, you have to take bloods, including at least 2 cultures. Especially if the child has got Lyme, then you have to take it from different sites. And remember, you have to do a routine workup. So you have to take full blood count, you have to take inflammatory markers, you have to take UNEs, you have to for LFTs, lactic acid, and also urine dip for urinalysis and urine culture. And after that, you can start them on broad spectrum or empiric antibiotics till you get the blood culture reports. In some of the cases, it's also important that you should be considering, apart from the blood workup, you need to do other diagnostic investigations like cross-sectional imaging. You might have to do a CT of the abdomen. Let's say there might be a deep-seated abscess, which can only be detected by a CT of the abdomen and pelvis. So you should be considering cross-sectional imaging. You should also be considering glucan and galactomannan tests. These are manual tests which are specially done to diagnose fungal infections, and especially in those kids where you have tried empiric antibiotics, and even after switching 1 or 2 courses of antibiotics, the child is still febrile, is not improving. In that particular case, you should be considering glucan and galactomannan tests, which are very good tests for detecting fungal infections. You can do some of the workup like nasopharyngeal aspirates for respiratory syncytial viruses. These days, you should also be considering COVID-19. So you should be taking the swabs for COVID as well. And if the child is able to do sputum, you should be taking sputum cultures as well. So once you have taken and done this diagnostic, workup, then it's time to start them on treatment. Now coming to the treatment. Now, if the patient is otherwise well, and he can be followed up every day, let's say he can come to the hospital, or the community team can visit the child in the community, and you can start them on oral antibiotics. And the one of the best broad spectrum antibiotic for outpatient management is comoxiclav. So comoxiclav can be started in a dose of like 30 milligram per kilogram body weight. If the child needs inpatient therapy, then you have to start them on empiric antibiotics, and then you can switch over to specific antibiotics based on the blood culture, urine culture, or other clinical consideration reports. So usually, if you start them on monotherapy, the drug of choice is usually piperacillin tazobactam. It's a broad spectrum antibiotic which can cover the pseudomonas as well. But let's say if piperacillin and tazobactam is not available, cefepime is another alternative, or ceftazidime or meropenem. So these are good monotherapy drugs to start a child who presents with febrile neutropenia. A child who has got indwelling lines and where you would be considering gram-positive infections like Staphylococcus epidermidis, then it's better that you add a second drug which has got gram-positive coverage as well, and that is vancomycin. Where there are abdominal abscesses and things like that, you would be considering anaerobic cover, and then in that particular case, you should be adding metronidazole. And in those kids who are presenting with fever, and despite, let's say, giving them 1 or 2 courses of antibiotic, they are not improving, in that particular case, then you should be considering about antifungal drugs as well. And one of the good antifungal drugs is amphotericin B, or you can even add fluconazole. And remember, so for inpatient therapy, the best thing is to start them on monotherapy: piperacillin, tazobactam, cefepime, ceftazidime, or meropenem. If you have to add a second drug to the monotherapy, remember you can add aminoglycosides like amikacin. But remember, aminoglycosides should never be started as monotherapy. They are always used as an add-on to monotherapy. So if you've started them on piperacillin, tazobactam, you can add amikacin, or you can add amikacin to ceftazidime, so on and so forth. But you should be following your trust guidelines. But if they are not improving on 1 or 2 courses of antibiotics, then you should be considering amphotericin B or fluconazole, which are antifungal drugs. So coming back to our case, the 4-year-old girl which was suffering from osteosarcoma and developed mild fever. Again, she was given oral co-amoxiclav, didn't improve. Then the antibiotics were changed to piperacillin tazobactam. She still didn't improve and still has got a fever of 39 degrees Celsius. So how would you manage this case? The best thing to manage this case would be to do a workup for fungal infection. So you would be doing the glucon and glucomannan tests, and you would be adding amphotericin B to your treatment regime. So in this particular case, the child would be continuing on the IV antibiotics, but you would be adding what? Amphotericin B or fluconazole, because there is a very high chance that this child might be suffering from invasive fungal diseases like invasive candidiasis or invasive aspergillosis. So this is how you would treat. To summarize, remember, a febrile neutropenia means that there is fever with a low absolute neutrophil count. And remember, you need to know where the fever is coming from and what is causing a low absolute neutrophil count. Like in most of the otherwise healthy kids, it would be caused by viral infections. But remember, the high risk cases are those who are on chemotherapy or those who have got a suppressed immune system secondary to HIV, secondary to steroids, or secondary to chemotherapy, if they are on chemotherapy for cancer, different types of cancer that they might be suffering from. So in that particular case, remember, you have to start them on antibiotics within 60 minutes. So you have to complete your workup, including full blood counts, UNEs, LFTs, lactic acid, urine analysis, and urine cultures, and then start them on empiric antibiotics. Empiric antibiotics, if the child is well looking and he can be followed up in the community, you can start them on oral antibiotics. But usually, in most of the time, we admit them because it becomes a medical emergency and you have to start them on empiric IV antibiotics, and then later on you can switch them depending on your blood cultures or urine culture report. And if they are not improving, then you can think of the second line drugs. You can add different types of coverages, like for staphylococcus, you can add vancomycin. For anaerobics infections, you can add metronidazole. And if you're considering fungal infections, then you can do glucon and glucomannan tests, and you can add amphotericin B or fluconazole. And remember, we continue the treatment till the child becomes afebrile and the infection is settled, and most of the inflammatory marker or other things, they come down. So this was all about febrile neutropenia. I hope you have liked this lecture, and if you have liked it, give me a thumbs up. And if you haven't subscribed to my channel, please do subscribe and press the bell notification icon, so whenever I upload a new video, you are always on board with me. So have a very good day, take care, and bye bye.